Imagine these tiny tangled blood vessels, almost like miswirings in our body, holding secrets about how we're built.
Uh-huh.
And this is where it gets really interesting. We're diving deep into congenital vascular malformations today.
Exactly. And for this deep dive, we're pulling from some really solid sources, chapters from Rutherford's Vascular Surgery and Endovascular Therapy. It's quite the reference.
Fertile authority, then.
Definitely. And we're specifically zooming in on how doctors use those minimally invasive endovascular techniques to manage these conditions.
Okay, so let's break it down. These vascular anomalies, what are they in simple terms? The book says it's like abnormal blood vessel growth, but crucially not cancerous, right?
That's the key distinction, non-neoplastic. And, to make sense of it all, there's this classification system from the International Society for the Study of Vascular Anomalies, ISVA.
ISSVA, right? I saw that mentioned. Last updated in 2018.
That's the one. It's really the standard framework everyone uses now. And it's super important because it helps guide how doctors think about diagnosis and, treatment. It moves things away from a kind of one-size-fits-all approach.
Makes sense. So how does ISSVA divide things up?
Well, broadly, you've got two main buckets. Vascular malformations, they're more common, congenital, so you're born with them, and like you said, not cancerous.
Okay.
And then you have vascular tumors. These involve abnormal growth, proliferation, really, of the endothelial cells, the ones lining the blood vessels.
Got it. And for this deep dive, we're sticking mainly to the malformations.
Precisely. And even within malformations, there's another split based on blood flow hemodynamics.
Okay.
You have low flow malformations involving capillaries, veins, lymphatics, or maybe a mix of those. Think slower pathways.
Like local roads?
Kind of, yeah. And then you have high flow ones. These are more like direct highways connections between arteries and veins. We call them arteriovenous malformations, AVMs, or arteriovenous fistulas, AVFs, much faster flow.
It's probably worth mentioning, even though it's not our main focus, that the textbook does talk about vascular tumors. Things like infantile hemangiomas.
Right, which usually shrink on their own, thankfully. And then more serious ones like angiosarcoma. But yeah, for today, we're keeping our eyes on the malformations.
So our mission for this deep dive, what are we aiming for?
Basically, to get a good handle on the fundamentals, what are these different malformations? How do doctors figure out which one it is, the diagnosis part? And then what are the main minimally invasive treatments? And actually, there's a shift happening towards understanding the why behind them at a molecular level. Finding drugs that target the root cause, not just managing symptoms. We'll touch on that later.
Sounds like a plan. Okay, let's start with diagnosis. The book hints it's not always straightforward. A bit of a puzzle.
That's a really good way to put it. Because they're pretty rare and different types can look quite similar, patients often end up at specialized centers.
Makes sense. You need the experts.
Exactly. These centers usually have multidisciplinary teams. You might have dermatology, plastic surgery, neurosurgery, vascular surgery, interventional radiology, all working together.
A real brain trust.
Sure.
And the book mentions a specific tool, a flowchart, the S.E. Mitchell flowchart, SEMVAFC.
Yeah, the SEMVAFC, we use it at our institution. It's basically a visual guide, a pathway. It combines the clinical findings, what the doctor sees and learns from the patient, with the imaging results.
Helps keep things systematic.
Right. It helps nail down the specific type of lesion. And what's cool is sometimes it points towards associated syndromes too, like Parkes-Weber or Klippel-Trenaunay.
So it connects the dots to the bigger picture.
Interesting.
Okay, imaging. How do they actually see these things inside the body?
Well, often the first step is duplex ultrasonography, or US.
Ultrasound.
Right. It's widely available, no radiation, pretty comfortable for the patient, plus you get real-time info on blood flow.
But there's always a but.
Well, the field of view is limited, so for bigger malformations or ones deep inside, it might not show you the whole picture. It's like looking through a keyhole sometimes.
Okay, so when you need the wide-angle lens, you turn to MRI, magnetic resonance imaging.
Exactly. MRI is generally preferred for most of these lesions. You get that wide field of view, fantastic soft tissue detail, and you can see how the lesion behaves with contrast agents. Rutherford's actually has figure 172.1 showing how MRI helps see the depth of infiltration.
So it gives a really detailed map.
Very detailed. MRI uses different sequences, different ways of taking the picture to highlight things like fluid, fat, and blood flow patterns.
And there was another MRI technique mentioned, DCEMRA. Dynamic contrast enhanced something.
Magnetic resonance angiography, yeah, DCEMRA. It's a bit of a mouthful, but it's incredibly helpful for classification.
How so?
It basically captures images over time as the contrast flows through arterial phase, capillary, venous, even a delayed venous phase. It's like watching a movie of the circulation within the malformation.
Ah, so you can see how the blood is flowing fast, slow.
Precisely. It helps distinguish arteries from veins, which is critical for telling, say, a high-flow AVM from a low-flow VM. And it's useful after treatment, too, to see the effects.
The book gets pretty specific about the MRI protocol at your place. Lots of technical terms.
Yeah, it's quite optimized. We use multiplanar T2 weighted images with fat saturation, T1 weighted images, and then T1 again pre and post contrast, also with fat saturation, plus a specific sequence called TWIST.
Twist.
Yeah, time-resolved angiography with interleaved stochastic trajectories. It's really good for capturing those dynamic flow changes quickly. Think of it like using different camera filters to bring out specific details.
And for someone trying to get their head around it all, Table 172.2 sounds useful.
Yeah.
It summarizes the MRI features.
Oh, absolutely. It's a great cheat sheet. It lays out the typical MRI look for different anomalies, infantile hemangiomas, VMs, LMs, AVMs, AVFs. A quick reference.
Okay. And what about conventional angiography? Is that still used?
Sometimes, yes. It's more invasive, involves injecting contrast directly via catheters, but it gives you incredibly fine detail of the vessel architecture when you really need that precise roadmap, maybe before a complex intervention.
Got it. Okay, that covers diagnosis pretty well. Let's shift to treatment now, starting with those low-flow types. Venous and lymphatic malformations are the most common ones you see.
That's right, VMs and LMs. Let's tackle VMs first. The book describes them as these sort of malformed venous channels, endothelium-lined like normal veins, but with abnormal smooth muscle in their walls. They can be single sacs or multi-lobed.
And mostly just random occurrences.
Mostly sporadic, yeah, though maybe 1–2% are inherited. Rutherford's lists examples like Arteriovenous Malformations, blue rubber bleb nevus syndrome, quite specific inherited types.
Those names are something else.
They are. And VMs can range hugely in size, from tiny spots to really diffuse ones affecting large areas. Head and neck are common sites, but also trunk, arms, legs.
And what they look like or feel like on exam.
Typically, they're described as these soft, compressible, bluish masses. Non-pulsatile, so no strong pulse felt. Figures 172.3 and 172.4 in the book show some examples. They might swell up a bit with increased venous pressure, like if you stand for a long time, or do a Valsalva maneuver.
That holding your breath and bearing down thing.
Exactly. And one really characteristic sign the book mentions is phleboliths.
Phleboliths, what are those?
Tiny calcified clots, basically, little stones within the VM. You can sometimes feel them, or they show up clearly on imaging.
Ah, bit of a giveaway sign. And complications. What kind of problems do VMs cause?
Quite a range. Pain and swelling are common, often from little clots forming phleboth thromboses. Infection can happen. Disfigurement can cause significant psychosocial issues. And depending on where they are, they can mess with function breathing, speech, walking. If they're in the gut or urinary tract, they can bleed and cause anemia.
Really impactful. Okay, what about the lymphatic malformations, LMs?
LMs are different. They're benign collections of abnormal lymphatic channels forming cysts. These can be macrocystic, meaning the cysts are pretty large, like over a centimeter or two. Figure 172.5 shows one.
Okay.
Or they can be microcystic with tiny cysts, or sometimes a mixture.
Also mostly sporadic.
Mostly, yeah, though some genetic syndromes like Turner and Noonan can be associated with them.
And when do these usually show up?
Often diagnosed at birth or in early childhood, but sometimes they pop up later. Again, head and neck are prime spots, but also chest, armpits, perineum.
And the exam findings.
Well, the macrocystic ones feel like those palpable, kind of rubbery, fluid-filled masses. If they're near the skin, you might see little vesicles containing clear or milky lymphatic fluid. The microcystic type might just look like general soft tissue overgrowth, more subtle.
And LMs have their own set of complications, too.
They do. Bleeding into the cyst is pretty common, causes sudden pain and swelling. They can also get bigger and painful if the person gets a systemic infection. Big ones in the head and neck can compromise the airway. And deeper LMs can lead to chylous effusions, that's lymphatic fluid leaking into the chest cavity or around the heart or in the abdomen.
Okay, so imaging these low-flow types, VMs and LMs,
Yeah.
what are the key differences on scans?
On MRI, they often look similar initially, kind of iso-intense to muscle on T1 images and bright hyper-intense on T2 images, though bleeding can mix that up.
Right.
VMs and macrocystic LMs look cystic, obviously. Microcystic LMs can seem more solid. the big differentiators. VMs often show those phleboliths, little dark spots on MRI, and they enhance with contrast, but typically in the later venous phase of a dynamic study. Figure 172.3 shows that.
And LM.
LMs don't have phleboliths, and crucially, they usually don't enhance internally, though the cyst walls might light up a bit. Figure 172.2 illustrates that. You might also see fluid levels within LM cysts if there's been bleeding.
What about ultrasound? Still useful here.
Oh, yeah. It can sometimes pick these up even before birth. It's great for differentiating flow, confirming they are low flow, and checking for complications like clots or bleeding. On US, they look like hypoechoic or anechoic cystic spaces, maybe with some debris. You might see the bright phleboliths with shadowing in VMs. And Doppler ultrasound typically shows minimal, if any, flow signal.
All right, we understand what they are, how they look. How do you treat these low-flow malformations? The book says they tend to grow and cause symptoms eventually.
They often do, yes. So treatment is usually aimed at relieving pain, improving function, or addressing cosmetic concerns, improving quality of life, basically.
What are the options?
Well, there are palliative things like compression garments to help with swelling, sometimes low-dose aspirin or low molecular weight heparin, LMWH, to reduce clotting risk, especially in large VMs. But those don't shrink the actual malformation.
So they're more for symptom management.
Exactly. For actually tackling the lesion itself, the main approach now, the first-line therapy really, is percutaneous sclerotherapy.
Sclerotherapy. That word comes up a lot. How does it work for these?
It's pretty clever, actually, using imaging guidance, usually ultrasound and fluoroscopy, which is like live X-ray. They guide fine needles directly into those abnormal cystic spaces. Then they inject a sclerosant.
A chemical agent.
Right. It's an agent designed to damage the endothelial lining of these abnormal vessels. The goal is to trigger an inflammatory response that leads to fibrosis, scarring, and hopefully contraction and shrinkage of the malformation.
And the book says this is pretty safe and effective.
Generally, yes. For low-flow VMs and LMs, it's become a standard effective treatment used all over the body.
What needs to happen before the procedure? Sounds like planning is key.
Oh, absolutely crucial. It starts with a thorough clinical evaluation history, physical exam, then usually a pre-intervention MRI to really map out the lesion, see what parts are treatable, identify any critical nearby nerves or structures, and very importantly, a detailed discussion with the patient and family about the risks, benefits, realistic expectations, and the fact that it might take multiple sessions.
You mentioned clotting risk earlier. The book brings up LIC, localized intravascular coagulopathy in VMs. Sounds a bit serious.
It's something to be aware of, especially with larger VMs. These malformations can have ongoing low-level clotting and clot breakdown happening within them. You might see elevated D-dimer levels, low fibrinogen, low platelets.
Okay.
Sclerotherapy itself can temporarily worsen this. So for patients with large VMs, particularly if they show signs of LAC, blood tests are done beforehand. They might even get LMWH before and after the procedure to help manage that coagulation issue.
And the procedure itself usually done under general anesthesia?
Typically, yes, for patient comfort, but also to ensure they remain perfectly still, which is vital for precision when you're placing needles near important structures. Anesthesia risk assessment is part of the workup, too.
Right.
The procedure itself happens in an angiography suite, basically an operating room with advanced imaging. Patient positioning is careful, sterile prep is done, and usually prophylactic antibiotics are given like cefazolin or clindamycin if they're allergic.
Okay, so needles in. What's next?
Using ultrasound guidance, they place one or sometimes multiple fine needles, maybe 21 or 22 gauge, into the VM spaces. Getting blood back confirms you're in a venous channel.
Makes sense.
Then often they'll do a direct venogram, inject a little contrast under fluoroscopy. This helps estimate the volume needed and critically identifies any large, fast-draining veins connected to the VM.
Why is that important?
Because if the sclerosant just washes out immediately through a big vein, it won't have time to work. So those draining veins need to be temporarily blocked, maybe with pressure, or sometimes tiny coils or glue are deployed via catheter first to allow the sclerosant adequate dwell time.
Gotcha. So you trap the sclerosant inside.
Exactly. Then the sclerosant itself is injected carefully under fluoroscopy. Rutherford's mentioned several common ones. Ethanol is very effective, though quite inflammatory. Sodium tetradecyl sulfate, or STS, often used as foam to cover more surface area. Ethanolamine oleate and bleomycin, which causes less swelling and might be safer near critical areas.
And how long does it need to stay in there?
Usually around 15 to 20 minutes, that's the dwell time. Afterwards, they might disconnect the syringe and see if blood flows back. If it does, they might repeat the contrast injection and add more sclerosant. Once they're satisfied the space is treated and closed off, the needle comes out, site gets cleaned and dressed.
And for LMs, the lymphatic ones, is it the same process?
Similar, but slightly different. For macrocystic LMs, they insert the needle, aspirate the lymphatic fluid out first.
Drain it.
Drain it, yeah. Then they partially replace that volume with the sclerosant. Doxycycline and bluamycin are common choices here. Sometimes for really big cysts, they might leave a small drainage catheter in place for a few days to allow repeated infusions.
And the microcystic ones?
Those are trickier because the spaces are so small. Bluamycin has shown some success, but if sclerotherapy doesn't work well, surgical resection might be the next step.
What about after the procedure? Recovery?
Well, first is recovery from anesthesia. Then you expect some local inflammation, pain, swelling. That's actually part of how it works. So pain management, ice packs, elevating the area are key.
Steroids are often used too.
Yes, frequently, especially for treatments in the head and neck or areas like the forearm or calf where swelling could potentially lead to compartment syndrome. Often, patients stay overnight for observation.
Follow-up.
Usually a clinic visit about a week later, and then a follow-up MRI maybe 1 or 2 months out. This assesses for any complications and looks for signs of treatment response, like decreased signal intensity on T2 images, less enhancement. But treatment is often incremental.
Meaning multiple sessions are common.
Very common, especially for larger lesions. It's often a staged process over months or even years. And interestingly, clinical improvement, the patient feeling better, having less pain or swelling, often happens before you see dramatic changes on the MRI. So the patient's symptoms are really the main guide for deciding when treatment is complete.
What are the main complications to watch out for?
Probably the most common issue is sclerosant extravasation leaking outside the malformation. Especially with superficial VMs, it can cause skin irritation, blistering, sometimes even skin necrosis or breakdown. Yeah, so careful monitoring under fluoroscopy during injection is vital. If they see contrast blushing outside the lesion, they stop immediately. If skin changes do occur, careful wound care is needed, sometimes specialist involvement.
Anything else?
Hematuria blood in the urine can happen, especially with large doses of sclerosant or contrast due to some red blood cell breakdown. It's usually transient, resolves with good hydration. A urinary catheter helps monitor. And then there's that rare but serious risk of acute compartment syndrome we mentioned in tight fascial spaces. Careful planning to avoid over-treating in those areas, plus post-procedure vigilance with ice, elevation, avoiding tight dressings, and considering steroids are all important.
The book also really stresses patient-reported outcomes, PROs. Why are they so important here?
Because ultimately, treatment success is about how the patient feels and functions. Are their symptoms better? Can they do more? Are they less bothered by the appearance? Especially with low-flow lesions where imaging changes lag behind, PROs are critical.
But there isn't a perfect tool for this yet.
Not really one specifically tailored for vascular malformations. Studies actually show that patient-reported improvement is often lower than what doctors might report based on scans. Existing general PRO tools might not capture the specific issues these patients face, so there's a real need to develop better specific PRO measures to truly understand treatment impact and guide decisions.
Okay. Are there other endovascular techniques mentioned besides standard sclerotherapy?
Yes, a few. MRI-guided sclerotherapy is an option for lesions that are hard to target with ultrasound, maybe deep in the abdomen or under scar tissue or bone. It uses real-time MRI for guidance, but it needs special equipment and training, so it's not widely available.
Right.
Then there's coil and glue embolization. This is used more for permanently closing off those fast-draining veins we talked about, or large venous spaces that aren't responding well to sclerotherapy alone. Glue can be injected percutaneously. Coils are usually placed via catheter. It can also be used before surgery to reduce bleeding.
What about non-endovascular stuff?
Laser therapy is mentioned, particularly for facial VMs. There's also electro-optical synergy, combining laser and radiofrequency. These can sometimes be combined with sclerotherapy if a lesion has both superficial and deep parts. And then there's medical therapy like sirolimus.
Sirolimus, how does that fit in?
It's an mTOR inhibitor. It targets specific cellular pathways involved in proliferation. It's actually approved for another condition, lymphangioliomyomatosis, that involves similar pathways. A trial showed it could be effective and safe for complicated vascular anomalies that weren't responding to other treatments. It really highlights the move towards understanding the underlying molecular biology and finding targeted drugs.
Fascinating. Okay, let's switch lanes now to the high-flow malformations, AVMs and AVFs. These sound like a different beast altogether.
They definitely are, hemodynamically speaking. AVMs, arteriovenous malformations, are these complex tangles, a nidus, of primitive arterial and venous channels that directly connect, completely bypassing the normal capillary network. Figure 172.6 shows a hand AVM.
So artery blood shunts straight into veins.
Exactly. This high-flow shunt causes problems. Locally, it can steal blood flow from surrounding tissues, causing ischemia, and raise pressure in the draining veins, venous hypertension. Systemically, it can overload the heart. They can pop up anywhere: CNS, limbs, trunk, organs.
And diagnosis. How do you spot these?
Often, the history and clinical exam give strong clues. Patients might describe a warm lump, maybe skin discoloration over it. You can often feel a vibration, a thrill, and hear a rushing sound with a stethoscope, a bruit.
Signs of that turbulent flow.
Right. In later stages, you can see ulceration, bleeding, and, as I mentioned, signs of high-output heart failure. There are staging systems, too. The Schobinger system classifies them based on clinical effects, how they're behaving. And the Yates system looks more at the angioarchitecture, the vessel structure, which helps suggest specific endovascular treatments.
Okay. And AVFs, Arteriovenous Fistulas, how are they different structurally?
An AVF is a more direct single connection between an artery and a vein. There's no complex nidus like in an AVM.
Simpler connection.
Right. Most AVFs are actually acquired, usually from trauma, like a penetrating injury. But some are congenital, true vascular malformations. These are rare, but can present dramatically in infancy with heart failure. The classic example is a vein of Galen malformation in the brain. In the limbs, AVFs can cause distal ischemia pain with walking, rest pain, ulcers, because blood takes the easy route through the fistula instead of going down to the foot or hand.
And the exam findings for AVFs?
Similar to AVMs in that you usually find a pulsatile mass with a palpable thrill and an audible bruit.
So imaging for these high-flow lesions, what are you looking for?
Imaging is usually needed to define the extent. Ultrasound is useful again. It can show the abnormal network or nidus in an AVM, identify the feeding arteries, which have high velocity flow even in diastole, and the draining veins, which show pulsatile, arterialized flow.
MRI again.
Yes, MRI is preferred for larger AVMs, like the one in figure 172.6. It shows the extent, proximity to critical structures. You typically see these serpentine dark flow voids on standard images representing the fast flow, and they enhance intensely in the arterial phase on MRA. You might also see surrounding tissue changes like edema or overgrowth.
And angiography.
Conventional angiography is really the gold standard here for detailed mapping. Its high resolution in both space and time is perfect for precisely identifying feeding arteries, delineating the nidus, and mapping the venous drainage. For AVFs, ultrasound shows that direct connection, the low resistance flow in the artery feeding it, and the arterialized flow in the vein draining it. MRA shows the abnormal connection with very early filling of the vein.
How are AVMs treated? The book says they're tough customers, prone to recurrence.
They are definitely challenging. They have a real tendency to persist and recur. The main options are surgical resection and endovascular embolization, sometimes used together.
Surgery sounds definitive if you can get it all out.
It can be curative if the entire nidus is completely removed. But because of their complex, infiltrative nature, complete resection is often very difficult or impossible without causing major damage.
So embolization comes into play.
Right. Embolization can be the primary treatment or used before surgery neoadjuvantly to reduce bleeding risk. It's technically demanding, requires meticulous study of the anatomy from the angiogram. The absolute key is targeting the nidus itself. That gives the best results and fewer complications. Treating only the feeding arteries further upstream often doesn't work well long term.
How do they actually do the embolization? Different approaches.
You can go transarterially, guide a catheter into the main feeding artery, then advance a smaller microcatheter right up close to the shunt and inject an embolic agent. Often ethanol or liquid agents like N-butyl cyanoacrylate glue or onyx. You might have to treat multiple feeders this way. Sometimes a transvenous approach is possible, especially if there's a single dominant draining vein or a venous sac. This is often preferred because there's less risk of accidentally embolizing normal arteries. Get a catheter into the draining vein, maybe inflate a balloon to temporarily block outflow, then inject the sclerosant or liquid embolic into the nidus from the venous side. Large sacs might get glue and coils.
Any other ways?
If transarterial or transvenous access isn't feasible, and the AVM is accessible, direct percutaneous puncture is an option, injecting embolics directly through a needle under imaging guidance.
But recurrence is still a big issue.
Unfortunately, yes. The book quotes rates like potentially over 50% recurrence within a year, and almost all within 5 years. So long-term follow-up, at least 5 years, is crucial. Patients often need repeat interventions if symptoms recur or the AVM regrows. And a major cause of failure or complications is treating too proximally, just blocking the main feeders, which often leads to collateral vessels opening up and feeding the nidus again.
Makes sense. What about treating AVFs?
Acquired AVFs, the ones from trauma, often close spontaneously over time, so the initial approach is often just conservative management with follow-up imaging.
Watchful waiting.
Exactly. But for congenital AVFs, or large acquired ones that cause significant symptoms and need intervention, surgery or endovascular repair are the options. A common endovascular treatment nowadays is placing a covered stent across the fistula point, basically relining the artery and excluding the connector.
Like patching the hole from the inside.
Precisely. Coil embolization can also be used sometimes, especially if there's a longer fistulous tract to block off.
It's really striking how different the strategies are for low flow versus high flow. Now, Rutherford also covers syndromes associated with these malformations. There's quite a list in box 172.1.
Yes, it's important to remember these malformations don't always occur in isolation. They can be part of a bigger genetic picture. We probably can't cover all of them, but hitting the main ones is worthwhile.
Let's start with Klippel-Trenaunay syndrome, KTS. What's the classic picture there?
KTS is known for a triad of features. First, a capillary malformation, typically a port wine stain. Second, a low-flow vascular malformation could be capillary, venous, lymphatic, or a mix. And third, localized overgrowth, hypertrophy of soft tissue and often bone in the affected area.
So you need at least 2 of those 3 for diagnosis.
Generally, yes. It's usually sporadic, not inherited. The vascular malformation component can be anywhere, but often involves persistence of an embryonic vein, like the lateral marginal vein in the leg.
And treatment for KTS.
It's really targeted at the specific components causing problems. Sclerotherapy for the venous or lymphatic parts, compression stockings, sometimes intravenous laser for superficial varicosities causing limb swelling or pain. One key point the book makes is you must check the deep venous system first before ablating superficial veins, because the deep system might be absent or abnormal in KTS, and treating the superficial veins could worsen venous insufficiency.
Good point. Okay, next up, Parkes-Weber syndrome, PWS. How's that different?
PWS is fundamentally a high-flow condition. It involves a congenital AVF, usually in a limb, associated with varicose veins and limb overgrowth. Figure 172.7 shows some features.
So AVF instead of low-flow malformation is the key difference from KTS.
Exactly. They might have a reddish skin stain too, but it's considered a pseudocapillary malformation related to the underlying high flow. The varicosities are secondary to the high pressure from the shunt. Lymphedema can also occur. And if the shunting is significant enough, it can lead to high-output heart failure.
Treatment for PWS.
Management is often conservative, if possible, because interventions can sometimes paradoxically worsen the shunting. But for really difficult cases with intractable pain or heart failure, super-selective embolization targeting just the fistula itself might be attempted.
Okay. And the last syndrome we should touch on is hereditary hemorrhagic telangiectasia, HHT, or Osler-Weber-Rendu disease.
Right. HHT is an autosomal dominant genetic disorder, meaning it runs in families. The hallmark is developing AVMs in multiple organs, commonly brain, lungs, liver, GI tract.
How is HHT diagnosed?
There are specific criteria, the Curacao criteria. They look for recurrent spontaneous nosebleeds, epistaxis, telangiectasias, those little red spots or lines on skin or mucous membranes, visceral lesions like AVMs in organs, and a first-degree relative with HHT. Having 3 or 4 criteria makes it definite.
And nosebleeds are often the first sign.
Very commonly, yes, due to telangiectasias in the nasal lining. Treatment aims to decrease bleeding and manage complications. Acute bleeds might need volume resuscitation. Chronic anemia needs iron. Pulmonary AVMs are a big concern because they can lead to stroke or brain abscess. They're often embolized if the feeding artery is over 2-3 millimeter.
What about other organs?
Liver involvement is common, ranging from small telangiectasias to large shunts. Treatment is usually medical management of complications like heart failure or portal hypertension. Embolization or even transplant are reserved for severe progressive cases. Brain AVMs have various treatment options: embolization, radiation, surgery. GI AVMs can cause chronic bleeding. Endoscopic treatments are common, but sometimes bowel resection is needed for severe cases.
It really drives home how interconnected these vascular issues can be. Okay, wrapping up, the book looks towards the future molecular and genetic targets. Sounds very cutting edge.
It really is. We're seeing this trend in oncology, precision medicine, targeted therapies based on specific genetic mutations, and there's a lot of overlap.
How so?
Researchers are finding that many of the same somatic or germline mutations that drive cancers are also implicated in vascular tumors and malformations and these associated syndromes. We already talked about the PI3 kinase AKT-mTOR pathway.
Right, leading to sirolimus use.
Exactly. That pathway is well established in driving vascular proliferation. But now, specific mutations like those in the PIK3CA gene are being found in endothelial cells of certain combined low-flow malformations.
Meaning drugs targeting PIK3CA could work.
That's the hope. There are already PIK3CA inhibitors used in cancer, and the book mentions promising early results using one of these inhibitors, BYL719, in patients with PIK3CA-related overgrowth syndromes. It showed reductions in vascular tumor size and limb asymmetry.
So the future looks more targeted.
Very likely, yes. As we understand the genetic drivers better, and with the rapid development of targeted agents coming out of oncology, tailored molecular testing and therapies are expected to become much more common in managing these complex vascular anomalies.
That's a really encouraging note to end on for patients. So just to quickly recap the main takeaways from our deep dive today.
Sure. We've established that vascular malformations are non-cancerous vessel abnormalities present from birth. They're broadly split into low-flow types like venous and lymphatic malformations, often managed with sclerotherapy, and high-flow types like AVMs and AVFs, where treatment might involve surgery, embolization, or both. And understanding the underlying genetics is becoming increasingly important for future therapies.
This has been incredibly insightful. It really highlights just how complex our vascular system is and how much progress is being made in understanding and treating these congenital conditions.
Absolutely.
It really makes you, the listener, think, doesn't it? How might learning more about these fundamental vascular development pathways not only help people with these specific malformations, but maybe even shed light on other conditions involving abnormal growth or vessel formation?
That's the big question, isn't it? It's what keeps driving the research forward in this really fascinating area of medicine. Food for thought, definitely.